Okay, I wish to introduce you to Dr. Mark Geier and his son, David Geier. Dr. Mark Geier has his PhD in genetics and was a professor at Johns Hopkins University. He's published more than 800 peer-reviewed medical articles and served as a scientific reviewer for autism grants for the U.S. government and has been involved in vaccine biologic litigation. David is vice president of the nonprofit 501c3 Institute of Chronic Illnesses Incorporated and COMED Incorporated. David's co-authored more than 50 peer-reviewed medical studies and has been involved also in vaccine biologic litigation. Please join me in welcoming both Mark and David Geier.
Thank you. Thank you for inviting us. We're going to make a presentation in amalgam, although most of our work is in mercury and vaccines and thimerosal. And then at the end of this, we're going to give you an experience that nobody on the planet has ever had before, because we're going to show you live something that we just, a new way of studying things that we just got in the last couple of days, and you'll be the first group ever to see it.
And regarding disclaimer, the work that we're going to show to you in the beginning part of our talk was funded by the IAOMT. They funded a series of our studies examining the childhood amalgam trial that we're going to talk about. So what we're going to talk about in the beginning of this presentation is an overview of what's called the CAT study, or childhood amalgam trial. For those who are not familiar, I'll just try to give a quick overview of this particular study. This was a study that was funded by our U.S. government, specifically the National Institutes of Health, back in the late 90s, early 2000s. It was supposed to be a trial that would once and for all settle the issue of safety or lack of safety of amalgam fillings. It was a study that was done in children in Portugal, done at orphanages in Portugal. And the idea was to take the children and divide them into two groups. One group would receive on an ongoing basis for 8 years nothing but amalgam fillings. The second group, which was randomized also, was to receive nothing but composites for 8 years. During the course of the 8 years of trial, in addition to dental care, a whole list of biological parameters were measured on these children on a yearly basis. Urine tests were taken, blood tests, even neuropsychological testing. We became very interested in this trial because Dr. Woods from the University of Washington began publishing in 2006, 7, 8, in that time period, a series of results on the trial, claiming or purporting to claim that basically amalgam fillings were pretty safe based on what he was finding. Our good friend and colleague, Dr. Paul G. King, took a step when these studies were published, which was to ask Dr. Woods for the raw data from the studies, all of the underlying data.
And by law, if it's a study is done by the NIH on public funds, you're allowed to request the raw data, and they have to turn it over. Now, of course, doesn't mean they always do, but by law, they're supposed to turn it over.
And Dr. King was able to obtain all of this data, and we began looking at it with him. And when we started seeing what was in the data, we knew we needed to come to the IAOMT to fund a series of reanalysis studies, because Dr. Woods, unfortunately, was not telling the complete, accurate picture. He was telling what I think many in the ADA wanted him to say. Our first study published based on this data is this particular one. This is a study on our team. We had Dr. Carmody, who's a professor of epidemiology. We worked with Dr. Janet Kern, who's a professor of neurosciences, as well as Dr. King and us, to analyze the data from the childhood amalgam trial, and we examined urinary mercury levels. This is a description of the actual children in the trial. There were a total of 462 children enrolled into the childhood amalgam trial that completed it. The average age when these children were enrolled was about 10 years. You'll notice that there was approximately equal numbers of males and females. There was also a pretty good racial distribution that reflects U.S. population, white versus black, even some Asians. They then took a whole series of measurements on these children at baseline. They measured their lead level in their blood, urinary mercury levels, all of the urinary porphyrins, which we'll explain. So we examined this data in a very different way than Dr. Woods, and I'll show you his versus ours. But we took all of these parameters and we made a statistical model. Basically, we said, okay, these are the children in our study. We want to make each of these things shown in this table a variable. We then wanted to examine these kids to look at the number of amalgams that they received over the course of the study. And what you see is that at the beginning of the study, when they were 8 years old were the youngest ones, they were 10 surfaces worth of amalgam was the average amount of exposure. As these children were followed for 8 years, because kids were 8 to 10 years of age, you'll see that the 10 number almost doubled. So there was a significant amount of amalgam exposure occurring in these children. But we took it a step further. We didn't just want to say that a child was in the amalgam group versus the composite. We wanted to evaluate specific information about those amalgam surfaces. And it turns out in the data was detailed information about the size of the amalgam, small, medium, and large, the number of surfaces, even whether the tooth was filled, a baby tooth versus a permanent tooth. So we took all of this information and evaluated each year to calculate the exposure. And we even made models to evaluate the relative effects of size and baby teeth versus adult teeth. So for example, we found that in evaluating small, medium, and large fillings, that the relationship was one of a linear one, meaning that if you had one surface in a small one, let's say, you counted that as 1. When we went to medium, it went to 2, large to 3, 4, 5. That's a linear relationship. It could have been a case where it might have been exponential, meaning it went up faster and faster, or it could have been another kind of relationship. So we actually found that in the data. And by the way, that's something that I think that should be studied a lot more. We did this in a mathematical way. People in a physiological setting, whether it's in actual people, or I know IAOMT has been working with mannequins, should really see the effects of size, composition on how much mercury comes off so that we could even better figure out what that relationship is. When we looked at the baby teeth as a comparison, we found, again, using mathematical relationship, that basically they had half the effect. So if it was a small filling in a permanent tooth, in this data, that would be equal to half. So that 1 would be a half score. And it also followed a linear relationship. A final piece that's very important in this study is that the children are obviously getting older. They're starting off young, and by the end, they're almost full-grown adults. They're changing physiologically. An 8-year-old weighs maybe 30 or 40 kilograms. An 18-year-old probably weighs 70, 80 kilograms. So their body composition is different. The amount of dose per kilogram body weight is changing. So we used BMI references for age and gender to take the dose of mercury exposure and to average it out over that weight. And using this kind of a model, this is our overall result, looking at urinary mercury levels. And what we're able to show here is what's called a beta coefficient. That's at 0.018. This is an actual value that says how much urinary mercury levels go up as a function of the number of amalgams. So it's not just the case, well, some people have amalgams, some don't, and it raises urinary mercury levels. It's actually a very, very precise scientific measurement. We can say per unit of amalgam surface, that's how much it goes up. And then we did statistics on it, and it's incredibly statistically significant, meaning that we have a great deal of certainty that that is a measurement of how much the increase is. So you can plug into this number, a person comes in with 10 surfaces of amalgams, 5 surfaces, and actually equate how much it's going to raise urinary mercury levels. And let me just show you how crude the work of Dr. Woods was on this subject. He published on this in Environmental Health Perspectives in 2007. And this is an idea of his kind of way of looking at it. First of all, we gave you a precise scientific measurement. His looks like spaghetti. What he's showing, if you can follow him, is that there are different panels. This is panel A, meaning children at baseline that had 0 to 4 amalgams when it was first placed, when they first started the trial. Panel B is 5 to 9. C is greater than 9. And then within each of these respective charts, the lines going up and down and jumping all around are the level of urinary mercury based on the number of additional amalgams that were placed. So again, very crudely, if you look at people who had no additional exposure, that's clear circles, and only had 0 to 4, not no exposure to mercury amalgams, but just a little bit at baseline, that's this clear line that's sort of down here at the bottom. That's kind of your reference. That's how urinary mercury changed in these kids as a function of their 8 years of follow-up. By contrast, if you really wanted to look at high-dose exposure, we come to panel C. So these kids got greater than 9 initially, and then the grade in diamonds represent people who got 9 or more amalgams subsequently, and you can see how it shot way up here into the high levels. So they had a change of almost 3 micrograms of mercury per liter urine if you got basically maximum kind of exposure, whereas the kids who got none or had very little exposure to amalgams and none subsequently, you can see that their overall change is roughly 0. But this is a very qualitative way of looking at it. I can't tell you statistically, is this number really different than that number? Well, eyeballing it looks different, but you can't really figure it out. And that's what everybody's after. We want to know what are amalgams doing to physiology, to urinary mercury, or whatever the parameter is.
Let me make a comment, because I'm a person that likes to make things very simple. And David gave you some mathematics. But just to understand the idea, if you have 2 groups, and in one group some are big, some are small, in all the groups, some of them get, the one that's in the mercury group might not get any mercury because he was in the group, you start creating a lot of noise, because there's a lot of variables. But you're not interested in the noise, you're interested in what the effect is. So if you look at it individually by using all the information you have, you get a precise answer. And if you have enough noise, you get that, and it may or may not even be statistical, but it's not the question. It doesn't answer the question. And this is true throughout epidemiology. The more noise, the more things you know that you don't include, the more likely it is to look less impressive, which is what he did.
And to translate this, this is actually from our paper now. This is sort of what Woods was doing, but much more precisely. This is the exact difference between the ones who had, we chose a average level of exposure to amalgams at each age group as they got older and older, versus people who had no mercury amalgam exposure. In other words, they got nothing but composites.
But you understand they could be in a group that's amalgam that had no amalgams.
Yeah, well, this says, based on our model, an average level, you could have somebody, obviously, in the trial who was in the amalgam group who had none placed. You could be in the amalgam group and had a whole bunch placed. This is just using our model to give you sort of what you could expect as the effect of amalgams. So, for example, among 8-year-olds, this is in the beginning of the study, these were, if you recall, people that had, on average, 10 surfaces of amalgam. They had 3.28 micrograms of mercury per liter in their urine. Those who had no amalgams placed at that time, 2.77. The relative difference is about 0.51 micrograms of mercury. As the study progressed, and we're looking at average level of exposure, we know that the kids down here, by the end of the study, on average, had almost 20 surfaces of amalgams in their mouth. You can see that the controls actually show some decreasing trend going on, and the relative difference approaches about 1 microgram of mercury. So again, just sort of eyeballing it, what it's saying is there were twice as many surfaces of amalgams at the end of the study as the beginning. That translated into about a 1 microgram of mercury difference on the urinary mercury levels. And let me point out a couple of things to consider, which is that, yes, these are controls in the sense of this is a background environmental exposure in Portugal, but you'll notice there is quite a bit of urinary mercury. These kids had a lot of mercury exposure, probably through fish consumption, maybe through vaccines. This is not an ideal population to really see the true effects of amalgams. And it's an interesting thing to think about, that if you had a population, let's go to a very big extreme. You had somebody that had, let's say, 100 micrograms of mercury per liter in their urine. So maybe they worked in a factory or something. That was your background group. And you took some of them and you put amalgam fillings in their mouth. And you followed this pattern of exposure that occurred in the amalgam trial. What you'd find at the end is that those individuals would end up with 101 micrograms of mercury.
A 1% increase.
And
but if they started out at 1 and stayed at 1 and then went to 1, they'd have a 100 or 50% increase. So the background makes the increase percentage-wise look smaller.
Percentage or relative-wise. This relative increase, it's 2 to 3. If this number was, let's say, they had really low exposure, we could make it even 0 if they had no exposure at all. If the only source of mercury exposure in the world was from an amalgam, this number would be 0. This would be 3.04. 100% of the mercury would be coming from an amalgam. So these kind of tricks, or if they're not tricks, this kind of understanding is very important to know what you're looking at. You can make very large effects look very small and very small effects look large, all based on how relative differences. And we concluded in our study, it's obvious that Portugal was taken as a group as a way to have not a minimalist exposure to environmental mercury. It was pretty darn high in these kids. And there's another point is that whatever was happening in these children, you'll notice there's a function of age. As these kids got older and older, the ones who didn't have the amalgams ended up with less and less urinary mercury coming out. And from the raw data, we couldn't tell why. I don't know if they stopped eating fish, the environment was cleaned up. We have no idea why, but the background part tended to go down throughout the course of the study. The same thing is happening, you'll notice, in the amalgam group, that urinary mercury is going down. It's just not going down as fast. The relative difference is actually increasing because of the amalgam exposure. And let me show you from Dr. Woods' work. I know many of you saw Boyd Haley present this. And people have looked at this, including Dr. Woods. He concluded, let's take the boys, which is shown on this side, panel A. The round circles represent the amalgam group for follow-up. So they initially place the amalgams. You see it went up, and then it starts tracing down. This is the composite group, which is here. You could look at that and say that actually amalgams only initially contribute to urinary mercury, and then it looks like it's going down. Yeah, well, it's going down, but also your composite group has a difference going on. So what you're really interested in is all of these variables. Sex matters because boys versus girls, there are big differences. It matters what the relative difference is between these groups, too. So his data gives you all kinds of perceptions visually that are not necessarily mathematically in the data. We did a second study on Woods' data looking at urinary porphyrins. And this is something I've talked to many people here in the room that we're very, very keen on. Urinary porphyrins are a very interesting physiological measurement that anybody can look at to measure ongoing exposure to heavy metals. And let me just explain what porphyrins are for those that are not familiar. Porphyrins are derivatives of the heme synthesis pathway. This is the heme synthesis pathway. Heme, like in hemoglobin, which is inside your red blood cells. Turns out that almost every cell in your body does this and produces heme.
This is an electron acceptor in the cycle as well as being in hemoglobin.
In the case of the kidneys do this same thing. They produce heme, but through various oxidation steps, you produce in your urine these byproducts called urinary porphyrins. These are derivatives of heme synthesis pathway that are water-soluble that come out in the urine. And what is known is that different metals will inhibit these arrows, which are enzymatic steps. You could inhibit here, and so on. Mercury is shown inhibits this enzyme here, the UROD enzyme, and also the CPOX enzyme, which produces elevations in these three specific porphyrins. That's specific to mercury.
That's been known since at least the 60s, early 60s, published in every NIH journal.
It's been done in animals, it's been done in humans, it's even been done in dentists as a marker for mercury poisoning. And pre-copper porphyrin, by the way, this one, is not a normal porphyrin that appears in the urine. If you could completely remove mercury from the world, pre-copper porphyrin would not exist in the urine. It only exists as an aberration of mercury causing problems in the heme synthesis pathway.
We've spent a lot of time studying this, and in fact, we've published that these are elevated in autistics. The more severe they are, the more elevated. And our work has now been reproduced in 7 different laboratories around the world and published from them.
And let me just say one more thing about porphyrins. If anybody does this analysis, let me give you some important caveats. One is that the porphyrins, these metabolites, are sensitive to light. So if you do this on yourself, you do it on a patient, don't just have them collected in a jar and leave it on the counter. They'll go bad. Another important part is you need a fractionated porphyrin. These are the different fractions, the different isolations. If you do a total porphyrin, it'll give you a whole gamish. It won't be a precise reading. So it's a fractionated porphyrin. The other part is that I would suggest you do it as a first morning urine. That way you have the overnight period, you collect the first morning pee at that time, and that way you don't influence it based on what you eat, you drink, none of that. So that's the best way to do it.
It's available from LabCorp, and they supply, if you ask them, black urine cups so that it'll be light, and you collect it in a dim room.
LabCorp does it, Quest here in the United States does it, Laboratory Philippe Auguste. And by the way, that laboratory, anybody can do it, whether you're a doctor, just a parent, anybody. You can order it yourself in France. It's about a $100 test. And if you do it here in the U.S. with a doctor's order, insurance will pay for it. So again, looking at these same 462 children, now you see why we put the porphyrins down, because we were interested in where the children started. Again, we find that the amount of exposure went up. So this is all the same data that you've seen before. And this is the important part, which is what did mercury exposure from dental amalgams do to these porphyrins? And what we found is highlighted in red is that the pentacarboxyl porphyrin, pre-copper porphyrin, and coproporphyrin, these 3, and these are the same beta coefficients, were statistically significantly affected by the amount of mercury exposure from amalgams.
What's interesting about it is, first, number of things. First, it's a biomarker for the body burden of mercury. But second, it is a damage. That is, when that happens, you're actually showing damage to the kidney. That's not supposed to happen. So it's both a biomarker and a marker of kidney damage.
So it was specific, you'll notice, to the mercury, to these mercury-associated porphyrins, whereas if we look at hexacarboxyl porphyrin, these 3, not associated with mercury, you'll notice their p-values, none of them are statistically significant. None of them are less than 0.05. And this is the first time, as far as I know, in humans that actually a controlled experiment was done. We've done this indirectly by people we think were exposed to mercury, and we measure their porphyrins and we find elevations. It's been done in rats and mice and various animals. But this was actually human experimentation. We have a known, specific, quantified exposure.
And randomized the patients.
In a randomized prospective study, we were able to directly correlate these porphyrins in humans with the amount of exposure. And just like the urinary mercury levels, these beta coefficients are saying, again, per unit of mercury exposure from an amalgam. So we could calculate whether you had 1 amalgam, 10, 20, or 30, whatever the number is, we can calculate from that very precisely how much the porphyrins are going to go up. Oops. Sorry. And this is looking at the delta change, meaning, again, starting with each year, we know the amount of exposure. So if we take, let's say, the pentacarboxyl porphyrin, this is the control group, this is the ones that had an average amount of amalgam exposure, it's 0.05 difference. And then as we proceed on down, here's the relative difference at the end. And you can do that for each one of these. Let me say something about the differences, which is that they range between 5 to about 15% increase as the number of amalgams went up. When we originally saw this, we were a little bit troubled at the sort of lack of increase. Why 5%, 10%, 15%?
In our artistics, it's hundreds of percent.
Well, it's, you know, double, triple, quadruple amounts. This is a relatively modest increase. But then we got to thinking more about this, and actually the data is telling us something profound. And what it's telling us is something that we know from human physiology. Most people that have amalgams placed are not acutely poisoned with mercury. You don't, as a dentist, put in 4 or 5 amalgams in somebody's mouth and they come back the next year or 5 years or even 10 years later and say they're dying of multiple sclerosis or some other kind of mercury poisoning symptoms. What we think, the model, if we stop and think about it, is that it's a cumulative effect over 20, 30, 40, 50 years of mercury exposure from an amalgam. At some point we reach a toxic tipping point. And these numbers kind of reflect that. If, let's say, over 10 years or 8 years, it goes up 10%, your mercury body burden, well,
per year.
And it's on a yearly basis, we'd expect to see over 20, 30, 40 years. Now you'll get to your doubles, triples, quadruple numbers, which are the levels associated with disease, which might fit with the human state of affairs. People that have amalgams, the big concern is when they get in their 50s, 60s, 70s. That's when Alzheimer's shows up. That's when MS shows up. We also did further assessment of the data from the CAT study, looking at kidney damage. Dr. Woods measured kidney integrity biomarkers in these kids. And we all know that mercury, especially inorganic mercury, likes to go to the kidneys. That's one of its principal places. We saw the porphyrins were going up. We'd expect or hypothesized it could be causing damage to the kidneys. And so we used our same kind of model to evaluate this data. And in this case, we analyzed 2 different parameters of damage to the kidneys. We looked at a marker that's a damage for the proximal tubules in the kidneys, which is called glutathione S-transferase alpha. In addition, we looked at GST, glutathione S-transferase pi, which is suggestive of damage at the distal tubules. So we were looking at 2 different sites in the kidney where it could be damaged. And we hypothesized, since mercury tends to like to go to the proximal tubules more than the distal tubules, you'd expect to see an effect, if there is one, from amalgams on the proximal tubules, much more so than the distal tubules. So we examined these children, all the usual parameters. This time, these are the actual GST alpha levels and GST pi levels at baseline. So you can see what we were finding as far as the levels. These are just exposure, like we talked about before. And what we found, is shown in red, was that GST alpha, the one that's a measure of proximal tubular kidney damage, was statistically significantly linked to the amount of mercury exposure from amalgams. And by the way, for those who are not familiar with kidney physiology, we did some research on this. Proximal tubular kidney damage is the exact site of chronic kidney disease. Chronic kidney disease is something that affects millions and millions of Americans. This particular damage that we were seeing is at a site that's associated with what chronic kidney disease is. And in the course of doing research, we even found animal models that showed that if you give a poison that damages the kidneys, of course you can cause complete kidney failure acutely if the dose is high enough. But if you give that poison at a very low level, at a chronic kind of dosing, what happens is you damage the proximal tubules over time, and eventually you end up with chronic kidney disease. And we hypothesized in the paper that perhaps amalgams may work the same way. It's not a case where you get a huge bolus dose of mercury from an amalgam and the kidneys give out. You get a chronic, low-grade, constant damage that's going on that, again, over decades may actually lead to chronic kidney disease. And if amalgams actually do that in a significant way, it would affect hundreds of thousands, maybe even millions of Americans. And this just shows the relative difference of the amount of effect from the amalgams.
Now, as you might imagine, as we published this, in each time we were polite, but in each paper we pointed out why our analysis was much more mathematical and scientific than that done by Professor Woods. They picked Professor Woods, and we had some interest in Professor Woods. We had dealt with
respect,
him before.
I think would be a better way to say it.
And he had published much more fairly than some of the public health people, some of the people on mercury. He seemed to be open. Well, at first he got angry. In fact, he didn't want to give us any more data. But he kept reading these papers, and what he did was he changed to our way. And for his next paper, acknowledging that we were right and he was wrong.
And in 2012, he actually came out with this study after our studies were published in 2010 and 11. And what he looked at was a mathematical model of exposure, not just amalgam versus composite, but using the same kind of methods to look at neurobehavioral effects from amalgams. And he actually reported in his study, and this is a table from it, that multiple different outcomes were significantly related to the amount of mercury exposure from amalgams. And you'll notice that he actually did it much the same way we did it. He's looking at cumulative mercury exposure as opposed to just an amalgam versus a composite. He's actually measuring how much mercury exposure is going on. Now, as opposed to some simple graph showing up and down, he's calculating beta coefficients. So he's actually using a model to calculate the amount of effect per unit of exposure to amalgams. And then these are the p-values, the ones highlighted in bold, are statistically significant results. It looks very much like what we were doing, and he found that mercury from amalgams, particularly in susceptible boys, caused a whole host of neuropsychological problems.
And it's interesting that he concluded that he's the first one to ever realize that there were susceptible boys. And of course, we have a zoo of papers in autism showing that it occurs in boys and susceptible boys and why it's susceptible, why they're susceptible to mercury. But welcome to the team. He's not first, but this is terrible because for the ADA, this is their guy now coming to our side. This should end the issue.
And to summarize, I one day was talking to Jim Love, as an attorney, and we were going through all of these studies, much like what I'm doing with all of you here. And what I pointed out to him, and I realized myself, was when you look at a clinical trial, like the childhood amalgam trial, it was designed a priori, meaning that there were specific parameters: urinary mercury levels, urinary porphyrins, kidney damage, neurological damage. All of these were selected as ways to evaluate the toxicity of amalgams. We all recognize that it would be virtually impossible to follow tens of thousands or hundreds of thousands of people prospectively and try to find the ones that develop Alzheimer's or multiple sclerosis. You can't do that.
We'll show you later you can't.
Until now, but you can't really do that in a randomized clinical trial. So instead, we pick acute things, something you can measure, something you can quantify now as a predictor of long-term damage. And that's what was done in the CAT study. And what was found now is that for every single domain, urinary mercury, urinary porphyrins, kidney damage, and now neurological damage, amalgams were associated with negative effects. And I think based just simply on that one fact that all of them by multiple people now, both us and Woods are finding this, you'd have to say that the CAT study is a killer for amalgams. I don't know how you can defend and say amalgams are safe, we're uncertain as to the effects of amalgams. All the excuses that are thrown out, they all been asked and answered. It's a dead and buried issue.
So we don't want to hear that you guys place any more amalgams, but I don't think we have to worry about that either.
But it's an interesting thing when somebody from the ADA says, well, the science isn't settled. We're not really sure what it does. What you respond is your own study now by multiple independent researchers is showing damage in every single area that was under study. What more do you need? I mean, do we have to wait till the body bags pile up? So new directions to consider. With all of this, as I call it, biologically plausible data, you notice everything that we said adds plausibility that mercury from an amalgam can cause harm. We didn't exactly link it to a specific disease. We did something very different, which was to look at quantitative measures of brain dysfunction in adults versus their body burden of toxic metals. And we analyzed toxic metals based on using the urinary porphyrins that I told you about. So we're not analyzing hair, we're not analyzing blood or urine. We're looking at something that's in the body having a physiological effect. And the brain dysfunction was also measured in a very quantitative way using what are called brain SPECT scans, single photon emission computed tomography. SPECT scans measure the blood flow, the functionality of the brain. And the nice thing is it generates a numeric number. It isn't, well, I looked at the scan, it looks good, it looks bad. It actually gives a numeric value. And in this study, what we measured was cortical perfusion index, or CPI values, versus the specific porphyrins. And we did this work with Dr. Pretorius from Cincinnati, Ohio. We looked at a consecutive series of 52 adults. These were people that came in with various endocrine problems, neurological symptoms, sort of routine kind of internal medicine patients that are chronically sick, that have neurological symptoms. And we did urinary porphyrin testing from LabCorp, and we did the SPECT scans on them. This is a sort of description of some of the actual medical diagnoses that these patients had. Very common things, bipolar, depression. We had Parkinson's, all of these kind of chronic diseases that are affecting so many of our society. And what we found was that there were significant increases, again, in the mercury-associated porphyrins, specifically, which are highlighted in red. The penta, the coproporphyrin, we measured here coproporphyrin 1 and 3, total coproporphyrins. These were all significantly elevated in patients that were severe, quantitatively severe on their SPECT scans versus those that were quantitatively mild. Statistically significant differences.
So you have a bad scan, you have bad porphyrins.
You have mercury-associated porphyrins.
If you have a good scan, you have less mercury porphyrins. Just like we found in autism. You have severe autism, you have a higher porphyrin, mercury porphyrin. If you have less severe autism, you have less severe porphyrins.
So what it's telling us, while this doesn't directly obviously say that amalgams cause all of the kinds of conditions that we were looking at, we know that amalgams are a significant source of mercury exposure, and we're finding that mercury exposure is correlating with human disease. Again, another powerful piece of plausibility. The next step in all of this is that we got to analyze the specific exposure from amalgams versus these kind of diseases.
In other words, supposing somebody said to you, okay, this is all very good, but I have, let's say, Parkinson's disease. Is it plausible that I have an increased risk because of mercury? And the answer is mercury could damage the brain in such a way that it could damage for MS and Alzheimer's, but not Parkinson's. I mean, you don't have any idea which disorders, and if it's true, did it raise my risk 10% or 20% or 30%? Or how many amalgams do I have to take to raise it 50% or whatever? That kind of data is completely lacking, and as David said, it would be very difficult to do a prospective study where you put 10,000 people and give them amalgams and not follow them for 70 years and, see the difference. It would have to be a big number because these disorders are not very common. So there's another way. And up until 2 days ago, there was no way.
And what I'm going to show you now is the first unveiling for anybody of our most recent database. We have been trying for many years to get access to large registries, large databases of patients who have not only medical problems, meaning diagnosed, let's say MS, Alzheimer's disease, whatever it is, but also have dental records. As you know, as dentists, you work in one area, doctors work in another, and unfortunately the two healthcare professions almost never talk to each other and certainly never share information about medical problems versus dental problems. So we have been trying for many years to find a database that would have such information, and we have finally gotten access to it. It's in the form of the Florida Medicaid database, starting in
Well, you
sorry.
work on that, and I'll explain it a little bit. The Florida Medicaid database is a database that has no bias. The way it was generated is if you lived in Florida and you were either a doctor, a dentist, a physical therapist, whoever, and you had a Medicaid patient, you would turn in a bill because you like to be paid. And on the bill, you'd have their name and all their background information, and you'd also have the diagnosis and the procedure and what you treated them with. If you were a doctor, it would be a diagnosis code and a surgery code or a medical code. If it was a dentist, it would be you gave them amalgams, you gave them, whatever it was. And this was all accumulated by the state of Florida as they paid you guys and the doctors for the procedure. So the dentist didn't know what the doctors did, and the doctors didn't know what the dentist did. Nobody, if there was any fraud in it, it had nothing to do with, a direction. And we have the data from 1990, actually through 2009, or 10, but we only have it loaded through 2007 at the moment. And that's something like 9 million patients over 20 years. And it's taken us 2.5 years to make it analyzable because it represents 1.4 billion, not million, billion medical records that our computers have to go through, and you put that on a desktop, it isn't going to work very well, and it's not arranged in a database. It was just typed out. So we had to make a supercomputer, and we couldn't afford or have the facility to have a big, mainframe with refrigerated floors and vibration-free and a team. So we had a developer develop what is basically a desktop that has the power of a supercomputer. It has 20, you know how you have like a machine that has dual Pentiums? This has 24 Xenon processors. It has an electronic hard drive, because if you load that much, it takes forever for it to load, even though your hard drive seems fast. The electronic hard drive is sort of like your thumb drive. It's really quick, but it's tiny. Well, this is a giant one, and it has 48 gigs of RAM and 3 screens, and it's taken us 2.5 years to make the equipment, to have the programs written. You can't put it in Excel or anything. You have to have a special program. And today, as in 3 days ago, actually, we have now access to where it's in a database, and then you have to put it in a database in a way that you can make inquiries that scientists like us can make rather than a computer program. You don't want to ask the program every time you have an inquiry to write me a program. So they're working on this.
So what we're showing you now is, those of you who have been following on the screen, I'm actually remotely logged into a server computer that has this. And the actual analysis, we're looking at an Excel file, Excel folder, just like what you have on your desktop. And on the right-hand side, where the mouse is, we have specific measurements that we can look on those 1.5 billion claims. So, for example, why don't we take, this is a diagnosis listing, why don't we take a look at diagnoses? So we take diagnosis, we want to filter the data by diagnosis. So it comes over here. We simply pull this up. Let's say we wanted to look at Alzheimer's disease, since we've been talking a lot about neurological dysfunction. It actually has a logic, maybe a little hard to see for some of you, where we're searching by text. So this is Alzheimer's disease popped up.
But he has every single diagnosis that medicine ever uses in that.
Yeah, it has what are called ICD-9, International Code of Disease, 9th revision. So this is a ICD-9 code for Alzheimer's disease. This is based on medical diagnosis. So we select that, and we hit OK. What we're doing now is a search of those 1.5 billion records. We just completed it.
By the way, a desktop would, on some of these, a desktop would take up to 7 years for the search. We're a little faster than that, We don't want to wait 7 years. To put it all together, our programmer, who's a famous programmer for big databases, said it would have taken 7 years to assemble in the desktop. Ours did it in 17 continuous days of running. And as you can see, when you do a search, it does it pretty darn fast.
So here's the answer to our question. There are, and I can't even see it, 646,000? Jeez. Can't. Sorry.
That light is.
No, it's fuzzy.
Oh, okay.
Let me try it this way. Still can't see. 649,600 records. So those are the number of claims. Of course, the issue with that is an individual could have more than one claim that they're actually having that diagnosis. Somebody goes, they get diagnosed with Alzheimer's, they go back again, it appears in their records again. So we can actually filter the data.
We have all these subroutines on the right.
Routines that you
can do. So the routine here is to say, just count each patient the first time you find them. Don't count them over and over again. You can count them either way. For amalgams, you might want to count them each time they have an amalgam. But for Alzheimer's, you don't want to count it, you know, they went in this week and next week and next week. You don't want to count them all. You want to count the first one. So we have, by clicking on a button, we can tell which way to count it. So now it's searching that. This is real-time search. I mean,
this is real-time search.
Yeah.
Through all
they're the patients, actually.
So now they've on the left-hand side, where I'm highlighting over here, these are the actual unique identifiers for each patient.
And we allow them to take the names out and just put an identifier because we don't want to know the names. So that's those. If there were names, those would be the names of the patients. And next to it is how many times, how many records they have. You know, they've been in 7 times complaining about it, 4 times, 100 times, whatever it is.
So the answer is there are 27,322 unique individuals that have an Alzheimer's diagnosis in that data.
How many boys?
And then if you wanted to apply
what we're doing is you're cutting the data from the big thing down to smaller, and we can cut on these general procedures. These kind of procedures will work on any study, whether it's amalgam or vaccine or you know, what aspirin does or whatever. We're trying to make general routines that will apply. So you might, you know, you certainly might want to ask how many patients rather than how many records, so we showed you that one. You might want to ask how many boys versus how many girls, so it'll search that next. And we're working on it. There's going to be lots more of these. Our program has to write each of these subs. But once you have a sub, you can use it on any database that you want. So as we you know, increase our ability, we can ask more and more questions immediately.
So if we want to look at gender, let's say we want to find how many males.
So now it's going to search those unique ones and find out how many males. It could also search the ones that are counted many times and find out how many males. You can do anything you want.
It's thinking. Let me minimize. While it's thinking, oops, what did I do? That was bad. Oh, it's this one.
Maybe it hung, huh?
No, it didn't. Well, let me skip out of this so you're not just sitting here waiting for it to do that. Let me show you something else, which is in the case of amalgams, I've actually gone through the data. We have this neat chart to look at, which is the database has specific codes for number of amalgams or the number of surfaces.
Maybe you guys use them if you have Medicaid.
So, for example, in the first series, we have procedure code here is for amalgams 4 or more surfaces in primary or permanent teeth. The row labels shown here represent the specific years in the data. To the right represent the number of times claims were filed for those. So, for example, for 4 or more amalgam surfaces between 1990 and 2008, there were 38,000 of those particular codes filed. If we take something a little more realistic, like 3 surfaces, there were 154,000, almost 155,000. For 2 surfaces, 612,000. And you can see they're down to 1. So it's very neat from the point of view that we can see that there are millions of amalgams that were placed during these years. In addition, we know from the data shown right below, we have information as to the resin-based composites that were placed. Starting on the right-hand side of the screen are for 1 surface. These are 2 surfaces, and then 3 or more surfaces. And these are based on posterior placements. So there are hundreds of thousands of those, and then we have separate code for anterior placements. And we actually can see a phenomena in this data of what's happening, which is that amalgams, at least in Florida Medicaid, starting in 2004-05 time period, are actually going down their use. The amount of composites have significantly increased to to be almost, I think, more than a majority. And we've also seen the transition between the posterior and anterior of the mouth.
In the early years, nobody placed posterior composites because they were placing them, you know, for appearance. So they placed anterior, and then the numbers are very small. And then as time goes on, people started placing posterior ones as well because they were doing it presumably for safety, not for appearance. So it gives you an example of the kind of search you can do. Now, obviously, we now need to link these to various diseases. What's the risk of these? And
so what we would do, just theoretically, to design a study, we would take people who had, let's say, Alzheimer's disease diagnosis, like I was showing you, and we look back through their records, in the best cases, maybe up to almost 20 years from the time of the initial Alzheimer's diagnosis. We calculate how many amalgam surfaces were placed during those years. We calculate how many composites, and we can find the overall exposure in that population. We then can compare it to controls, meaning people of similar age, gender, even where they live in Florida. We have that information to figure out, are amalgams really a risk factor for Alzheimer's disease? And if so, how much?
They might be twice as high, 3 times as high. We also have the money.
We know how much each of these claims, because they're actually financial claims, we can tell precisely how many dollars and cents were spent on the medical conditions, on the dental conditions, all of that's in the data.
And interesting where you live, because, you know, is it higher if you live near a power plant? Is it higher if you live in a you know, city area? Is it higher? We have all the zip codes. We actually have the doctors' names. The only thing we let them take out was the patients' names, which are coded.
So this, I think, is a very important way forward now for all of us as a collective group, since we all care so much about mercury exposure from amalgam fillings. What precisely is it causing? How much risk does it have? We can now ask and answer those questions specific to that. And as you might imagine, we're just talking about amalgams. Anything in dentistry. I know there's discussion about things like
root canals.
Root canals. Does root canal cause? You can fill in the
blank.
Increase your risk. Or increase your risk.
Too strong, but increase your risk.
Increase your risk.
And you can fill in the disease you want.
Any disease, any kind of dental procedure, it's all in this data.
And understand, of course, that you're interested in dental. We're interested a lot in vaccines. But it's not limited to vaccines in dental either. It could be how many people, you know, have, you know, bladder surgery, and do they develop more cancer? I mean, I'm just making something up.
All of health.
Anything, because it has every medicine coded, every procedure coded, and every outcome coded. And how much they cost. Nobody, anywhere, certainly not in the United States, including the feds, as far as I can tell, have anything like this. And then we can now answer any questions you want. And in fact, the problem is to get enough people to work on it. We were so excited we got this working finally so we could use it. It was about 10:30 in the morning. By noon, we had enough data for 4 studies. Unfortunately, it would take many weeks to write the studies, and by that time we'd have 400 studies. I mean, and we can't think of all of them, and there are going to be people in the medical and dental world that are going to have interesting questions to ask of this database that can be answered in a relatively short time. And what we need to do is write those subs so that they can do the common things, split it out as to age. You know, another thing you hadn't thought about, but we've thought about is, for example, when you search somebody, you want to see if let's say you did the search that David said, you took all the people that have Alzheimer's, and then you wanted to see what their composites were and what their amalgams were, but you also want to only use people that were enrolled in Medicaid for 10 consecutive years. You don't want people that were in for 1 minute. So you want to pass through and ask them. We have the enrollment files. So you can specify how long you want them to be in. You can specify that they didn't go out or they didn't go out more than 1 month or anything you want. So it's a multi-complex thing. This is the very beginning, but this is the first time that this has been available. We've seen the government's databases. We've been ordered in to be allowed to see their secret databases. Nobody has anything like this for medicine and dentistry, and it should be developed to help all of us, not just the issues here, but on all issues in medicine, dentistry, and anything else related to that.
Thank you very much for inviting us.
Thank you. The AGD code for this presentation is DMG, as in David and Mark Geier.